Hello viewers, welcome to our channel JD Pharmacoveda. In this video, we are going to discuss about the drug therapy or the drugs used in the treatment of heart failure. So before entering into our topic, let's see a quote written by the famous scientist Stephen Hawking. He says, "However difficult life may seem, there is always something you can do and succeed at." So then, heart failure. So heart failure occurs when cardiac output is insufficient to meet the demands of tissue perfusion, or is able to do so only by elevating filling pressure. Heart failure may primarily due to systolic dysfunction or diastolic dysfunction. So this systolic dysfunction, in case, this refers to deficient pumping action of ventricles. Then diastolic dysfunction means the ventricular wall is thickened and unable to relax normally during diastole. So that is, ventricular filling is impaired and stroke volume is reduced, but the ejection fraction may be normal. So then, in this therapy, there is two distinct goals. So number one, relief of congestive or low output symptoms, then restoration of cardiac performance and treatment of acute decompensation. So this can be achieved by first inotropic drugs like Digoxin, dobutamine or dopamine, inamrinone or milrinone. Then diuretics, so drugs Furosemide, thiazides and metalozone. Then renin angiotensin system inhibitors like AC inhibitors or ARBs. Then vasodilators like hydralazine, nitrates and nitroprusside. Then synthetic BNP like nesiritide. Then beta blockers like metoprolol, bisoprolol, carvedilol, nebivolol. Then the second goal is to arrest or reversal of disease progression and prolongation of survival. This is possible with AC inhibitors or ARBs, beta blockers, aldosterone antagonists like spironolactone, eplerenone. Then neprilysin inhibitor like Sacubitiril. So first, cardiac glycosides. So in the previous video in Digoxin, we have explained all kind of mechanism of action, pharmacological action like this in previous video. You can refer that in our description. So cardiac glycoside, the only cardiac glycoside in clinical use today is Digoxin. So Digoxin is a positive inotropic drug which affords symptomatic relief primarily in systolic dysfunction or when congestive heart failure is due to atrial fibrillation with rapid heart rate. It is incapable of reversing or retarding the pathological changes of heart failure or affording prognostic benefit. Digoxin induced enhancement of contractility increases ventricular ejection and shifts the curve relating stroke put to filling pressure towards normal, so that adequate output may be obtained at a filling pressure that does not produce congestive symptoms. Then it improves the tissue perfusion, results in withdrawal of sympathetic overactivity like heart rate and central venous pressure are lowered towards normal. Then compensatory mechanisms retaining sodium and water are inactivated. Diuresis occurs and edema is cleared. Dosage: Digoxin therapy is now initiated with the estimated maintenance doses like 0.125 to 0.25 mg per day without any loading dose. Then diuretics. Almost all cases of symptomatic heart failure are treated with a diuretic. So these diuretics can decrease preload and improve ventricular efficiency by reducing circulating volume. It can remove the peripheral edema and pulmonary congestion. So when used in IV furosemide, promptly increases systemic venous capacitance and produces rapid symptomatic relief in acute left ventricular failure. Then renin angiotensin system inhibitors. Since ROS activation is pivotal to development of symptoms and disease progression in heart failure, they afford symptomatic as well as disease modifying benefits in heart failure by causing vasodilatation, retarding or preventing ventricular hypertrophy, myocardial cell apoptosis, fibrosis, intercellular matrix changes and remodeling. Then vasodilators. The direct acting vasodilators are primarily useful in the treatment of acute heart failure that occurs in advanced cases or that follows acute MI and are infused IV for short periods to tide over crisis. The effects are, first, number one, preload reduction. Nitrates cause pooling of blood in systemic capacitance vessels to reduce ventricular end diastolic pressure and volume. Then number two, afterload reduction. Hydralazine dilates resistant vessels and reduces aortic impedance so that ventricle is able to pump more blood. Then number three, pre and afterload reduction. So the drug is sodium nitroprusside. Is a highly efficacy IV dilator with equal action on the two types of vessels. Then beta blockers. Extensive studies over the past 30 years have established the utility of beta blockers, mainly metoprolol, bisoprolol, nebivolol, and the non-selective beta and selective alpha 1 blockers like carvedilol in mild to moderate CHF. They afford survival benefit and are now part of standard therapy in CHF. Though the early hemodynamic action of beta blockers is to depress cardiac contractility and ejection fraction. After a couple of months, ejection fraction is generally higher than baseline and slow upward titration of dose. Then aldosterone antagonist, so like spironolactone and eprinone. First, it expands the ECF volume by increasing cardiac preload. Then fibroblast proliferation and fibrotic change in myocardium. So this may worsening systolic dysfunction and pathological remodeling. Then it can also produce hypokalemia and hypomagnesemia, which can increase the risk of ventricular arrhythmias and sudden cardiac death. So the aldosterone antagonist is a weak diuretic but can benefit congestive heart failure by antagonizing the above effects of aldosterone. They are used as an add-on therapy to AC inhibitors or other drugs in moderate to severe heart failure with reduced ejection fraction. They can retard, decrease disease progression, reduce episodes of decompensation and death. Then sympathomimetic inotropic drugs. So drugs with beta adrenergic and dopaminergic D1 agonistic action have positive inotropic property which may be utilized to combat emergency pump failure. So dopamine and dobutamine infused IV act promptly and afford additional hemodynamic support over and above vasodilators, digoxin and diuretics, but benefits are short lasting. They are particularly useful when heart failure is accompanied by low blood pressure. Then phosphodiesterase 3 inhibitors. Amrinone is a selective phosphodiesterase 3 inhibitor. So phosphodiesterase 3 is an isoenzyme is specific for intracellular degradation of cyclic AMP in heart, blood vessels and bronchial smooth muscle. So amrinone increases myocardial cyclic AMP and transmembrane influx of calcium ions. Both these actions may underlie its positive inotropic property. Next drug, nesiritide. This recombinant brain natriuretic peptide is being used by continuous IV infusion to relieve dyspnea and other symptoms in refractory CHF. Then sacubitril valsartan combination. So sacubitril is an orally active neprilysin inhibitor which prevents the degradation of endogenous ANP, BNP and other vasodilator peptides, producing vasodilatation, natriuresis and diuresis. So when combined with ARB valsartan, it has been recently approved for the advanced heart failure. Then finally, Tolvaptan. This is an orally active non-peptide vasopressin V2 receptor antagonist introduced for the correction of water retention and hyponatremia occurring in syndrome of inappropriate ADH secretion as well as in advanced congestive heart failure. So this is all about the therapy or the drugs used in the treatment of heart failure. Thank you for watching. If you like our video, please like, enter your thoughts in our comment section, share with your friends and subscribe to our channel.